As you will have learned by now, one of the main strategies we use in developing pharmacological treatments is to interfere with the synthesis or degradation of the neurotransmitters whose level we're trying to manipulate. You will find that easier if you're familiar with the synthesis and degradation pathways. This is the synthesis pathway for dopamine. It also includes the synthesis of norepinephrine and epinephrine, or noradrenaline and adrenaline, because they are part of the same pathway, and it doesn't hurt to remind you of this. So you should learn this pathway, and not the structures, not necessarily if you don't want to, I think it helps, but certainly the names of the chemicals and the enzymes involved in each step. Given that the problem underlying Parkinson's disease is a loss of dopaminergic signaling, it stands to reason that a strategy for treating it might be to attempt to restore dopamine signaling. And that's why the first-line treatment for Parkinson's disease is levodopa. And levodopa is none other than dopa itself, just a slightly different name. So the idea here is to provide the precursor for dopamine synthesis from dopa decarboxylase. It's usually given with a peripheral decarboxylase inhibitor such as carbidopa. And the reason for that is you've got to get the drug from the gut to the brain. And that means it's got to get through the intestine, where it will encounter dopa decarboxylase in the epithelia, which will try to degrade it. So we usually give it a peripheral inhibitor to stop it being degraded on the way. It has a short half-life, and about 80% of patients improve, and indeed 20% even restored to normal, but it's only temporary. It's a temporary measure. Its unwanted effects you might be able to guess from what you already know about dopamine receptors and what we're trying to restore. Involuntary movements, nausea, which is treated with domperidone, which is a peripheral dopamine antagonist, and the reason for that is that in addition to the central pathways we looked at, dopamine receptors are expressed in the chemoreceptor trigger zone in the brain, which is outside the blood-brain barrier, and its job is to detect toxins and to make us vomit. It also causes hypotension. Notice that dopamine is in the pre-pathway to noradrenaline synthesis, and psychotic effects, and you can work why that is because of the mesocortical and mesolimbic pathways also express dopamine receptors.
So the aim then of treating Parkinson's, what we want to do is to increase the amount of dopamine in the brain. So to do that, we give the patient levodopa. So what we want to do is to get that levodopa into the brain. But we have a problem because the levodopa, even before it makes this journey, gets catalyzed by dopa decarboxylase into dopamine, which is normally what we want, but the problem is this is happening in the periphery, and so that's actually stopping us getting the levodopa into the brain. We can treat that by a drug called benserazide, which inhibits dopa decarboxylase. But we're not all there yet because we've also got another one to contend with, which is catechol O-methyltransferase, or COMT as it's sometimes known, which tries to convert our levodopa into methyl dopamine. But we can inhibit that with tolcapone. So hopefully then by now, at least some of our levodopa is finally made it into the brain, where it's being made into dopamine, and we've achieved our objective of increasing the dopamine in the brain. However, we still have problems here because our old friend catechol O-methyltransferase is going to try and turn that dopamine into not methyldopamine, that's not quite right. It should be actually 3-methoxytyramine. I'll change that in a minute. And our old friend monoamino oxidase is converting it into dopac. We can inhibit these enzymes with Celyn, which inhibits monoamino oxidase, and COMT can be inhibited with our old friend tolcapone, from which you can deduce that tolcapone crosses the blood-brain barrier. So now let's correct this mistake here. This should be 3-methoxytyramine.
So here we're summarising the three main strategies for restoring dopamine levels. We can directly try to increase dopamine availability by giving levodopa, the immediate precursor. We can also, looking at the third point first, we can inhibit enzymes that degrade dopamine, monoamino oxidase and catechol O-methyltransferase. But the third strategy is to apply agonists that act directly on dopamine receptors. Here are some examples of agonists that act directly on dopamine receptors in the treatment of Parkinson's. On the left, we have drugs developed originally from ergotamine, which is a fungus which grows on wheat and which has caused some rather extraordinary effects, particularly in the Middle Ages, on villages which harvested wheat with ergot fungus growing on it and then ate the bread, and the ergot was then, I'm not sure whether it's directly or through its metabolic products, produced effects on D2 receptors and very much like LSD. So these have been replaced now with newer generation of drugs with fewer side effects, and you should be familiar with the name of pramipexole. It doesn't hurt to know ropinirole as well. Again, the side effects of dopamine agonists are quite predictable. They include things like gambling, sexual excesses and risky behaviour, and the reason for that is that dopaminergic input to the striatum is used as a cue in learning. So by having excessive stimulation of the dopaminergic system, we're effectively hijacking the reward system. So the brain's receiving too strong rewards, and that's why you get these inappropriate behaviours of an addiction nature. Celyn is the best known monoamino oxidase inhibitor used for Parkinson's. It's selective to the B subtype. It's actually metabolized to amphetamine, so you can guess what its side effects are. That's not that surprising because amphetamine itself is very closely related to noradrenaline, and its role as a drug of abuse is to compete with noradrenaline for reuptake, so that causes excess of noradrenaline in the synaptic cleft. Rasagiline is another monoamino oxidase inhibitor. Surprisingly, A somewhat different strategy for treating Parkinson's disease has nothing to do with dopamine receptors at all, but has to do with cholinergic signalling. And the reason for that is that you can think of the input to the cortex as being a result of a balance between an overall excitation via the dopamine system and an inhibition through the cholinergic system. So the idea behind this form of therapy is to say, well, we've lost dopamine receptors, let's also inhibit cholinergic signaling to restore the balance. As you can imagine, I think you know by now the usual cholinergic side effects: dry mouth, urinary retention and constipation. So it's not really used as a first-line treatment for Parkinson's disease.
On top of the pharmacological approaches that we've been talking about, new strategies involve things like deep brain stimulation, where electrodes are placed in the basal ganglia and a current applied in order to make up for the loss of firing of neurons and to stimulate certain elements of the basal ganglia. These are remarkably effective. Research is also being conducted into using pluripotent stem cells in an effort to replace the dopaminergic neurons that have been lost in Parkinson's disease. And there have been attempts using gene therapy, but so far these attempts have failed.